Our speaker today is Dr. Brian Berman. He's a professor of neurology and the Bemiss Endowed Chair at the Virginia Commonwealth University, which I'll refer to as VCU here. And he's also the director of the VCU Parkinson's and Movement Disorder Center. Dr. Berman completed his neurology residency training at the University of California at San Francisco and his fellowship training at the Movement Disorders unit at the National Institutes of Health under the tutelage of Dr. Mark Hallett, another well-known name to those of us in the dystonia community. After this fellowship, he joined the neurology faculty at the University of Colorado, Denver, where he established a national reputation in movement disorders and applied advanced neuroimaging methods to advance our understanding of all the disordered brain processes that underlie dystonia and Parkinson's disease. So after 10 years at the University of Colorado, he relocated back to VCU to expand his impact on the field and direct a movement disorders center there. Dr. Berman has served on the medical advisory board for the National Spasmodic Torticollis since 2013 and also the Benign Essential Blepharospasm Research Foundation since 2014. He's very active in these communities. His current research pursuits in dystonia include investigating the role that loss of inhibition, I think that's inhibition in the brain, plays in the disorder and assisting with the development of patient-centered outcome measures to help inform the development of new treatments for dystonia. And Dr. Berman has further long-standing clinical and research interests in the non-motor symptoms associated with dystonia, something I'm very interested in hearing about because I'm one of those people who do have non-motor symptoms with my dystonia. So with that, I want to introduce Dr. Brian Berman and take it away.
Thank you very much. I appreciate the introduction. And yeah, you're not alone. I mean, I'll talk about today just how common they really are in those with dystonia. And so I will get started with the talk here, and if people would like, they can either put some questions into the chat that I'll answer at the end of the presentation, or they can just wait till the end and we can have a discussion. So I try to leave enough room at the end that we have a good amount of time to ask questions and have a little more discussion. So yes, I'm here to talk about non-motor symptoms, and I titled it Beneath the Surface, Non-Motor Symptoms in Cervical Dystonia. And then I'm borrowing from a concept that came out originally around 2006, I believe, from Dr. Langston, who did some pioneering work in the cause of Parkinson's that was related to this drug heroin manufacturing. And at that time, people started becoming increasingly aware that these non-motor symptoms, the symptoms you don't see, really essentially outnumber the ones that are in the ones you do see, the motor symptoms. And so it sort of gives you the idea of the metaphor of an iceberg where you just see the tip. And so in Parkinson's, you see how there's the motor symptoms here, what people see, but a whole number of non-motor symptoms that are often bigger contributors to quality of life and disability than the ones we see. And we've actually developed quite a number of treatments that really help the motor symptoms and still find the non-motor ones to be quite a bit challenging. And just to put a little connection here with cervical dystonia, this week I received notice of a paper that was published that looked at the incidence of cervical dystonia in Parkinson's patients, and they had a rate of 34% of them had cervical dystonia. So it's common in that patient group as well. But if we borrow from that iceberg phenomena, so here is dystonia. And so we have the muscle contractions, fixed postures, tremors and such. And then below there's a whole range of non-motor symptoms that have been reported. And this is all of dystonia, but cervical dystonia is what we'll be focusing on today. And also I'll be focusing on just a handful of these. And so some of the major ones, but pain, fatigue, sleep disturbances, daytime sleepiness. And then we're also going to touch on the psychiatric comorbidities of anxiety and depression, which are also very common. So just to cover the objectives, my mouse is very sensitive here, keep moving it forward. But so we're going to review some the common ones that I just mentioned of the non-motor symptoms. And then we'll also give a little discussion about whether these are part of the dystonia syndrome of the disorder itself, or a response to the dystonia that is sort of causing these symptoms. And then a little bit about treatments for them as well. And then along the way, maybe there'll be a few pieces from art that some people have thought about and signifies that there was some dystonia in the past that people document through their artworks. So in 2013, the folks, some specialists, part of the International Parkinson's Movement Disorders Society, sat down and rewrote the definitions. This happens every so often where we sort of sit down with the experts and come up with the best definition for disorders, and in this case for dystonia. This is about the last time it was done, and they came up as a group with the definition that dystonia is a movement disorder characterized by sustained or intermittent muscle contractions causing abnormal, often repetitive movements, postures, or both. And so as I highlighted there in the red, this is really focused on the movements and the muscle contractions. And that's really how we define these disorders, just like in Parkinson's, even though it may very well be the non-motor, non-movement symptoms that really end up being more impactful. And then there's also the movements to help characterize dystonia from other kinds of movement disorders that we see in our specialty, that these movements are typically patterned, they involve the same muscles, generally speaking, they cause twisting and maybe tremulous or jerky. So this kind of amplifies the cervical dystonia case in quite a bit, which we also call spasmodic torticollis, as everyone on this call is aware. And they probably also are aware that when dystonia affects other body regions, we sometimes use different words to talk about those dystonias. So if there's excessive muscle spasms of the eyelids, for example, we call that blepharospasm. If it's of the vocal cords, it's often called spasmodic dysphonia. We can see it in different tasks, and so that's like task-specific dystonia. That might be writer's cramp or musician's dystonia. And so these are all different forms of dystonia that you're probably all aware of, and occasionally those who have cervical dystonia have other body regions that are affected. It's not uncommon. But if we focus in on the spasmodic torticollis, there is, generally we use the term cervical dystonia because there's so many different ways that the neck can move, and certainly the most common is torticollis. And I don't know if people are familiar with this terminology that we use on occasion, where collis is really the neck, and so this is turning of the neck that occurs. But there can also be sort of caput, so torticaput, which is the turning of the head. And so there's some slight differences. If you have a lateral collis, where the head is kind of bent over to or the neck is sort of bent to the side versus the head is bent to the side. And then we have anterocollis and anticaput, and retrocollis, retrocaput. So there's a variety of different ways that cervical dystonia can present. And we in general would talk about non-motor symptoms today. This is just going to be kind of lumping every one of these things together. So we're not really saying specifics, but there is some thought that these might represent slightly different conditions. And so future work will have to figure out if there's any differences in how these different presentations might affect the non-motor symptoms that one has. So let's talk about the cervical dystonia today. We're going to leave out this part about the muscle contractions and really focus here on the non-motor symptoms. And again, these are the list of the ones that we're going to discuss. So the first thing I wanted to say is non-motor symptoms are common. And this is just a recent study, 2020, of 102 Scandinavian patients with cervical dystonia. And the Scandinavians are thought to be some of the happiest people in the world whenever they're rated along the happiness scales. So this is generally a good population, positive thinking. But if you see in the cervical dystonia world that they have high rates of fatigue, and this is sort of different types of fatigue that exist, so general fatigue, physical or mental fatigue. And we're talking half of patients with general and physical fatigue complaints. Sleep impairment affected 2/3 of them. Again, 2/3 had anxiety, and about half had depression. So we're really talking like a large portion of patients who are experiencing these. And from another study, not only that, but about 1/3 of them with these non-motor symptoms report them to be so significant that they impair their activities of daily living. So this is just doing your daily things day to day, brushing teeth, getting food, can be impacted by this. So a serious issue. And this, so one thing just to say some of the, I'll be reporting some literature, or at least you'll be seeing some of the authors and papers where some of the data that supports what I'm talking about comes from. And there's one way to do this is to cite a literature review. And so there just happened to be one in 2020 that I'm going to be talking a bit about or citing. And this is, it was actually an Indian journal, but they used sort of international repository where these kinds of papers are published and stored, and did a search, and they looked at cervical dystonia along with some other terms, just like we were mentioning here in terms of anxiety, depression, sleep, and such. And they found 442 studies matched the search criteria. So it does tell you that it's growing in its research, and I would still say it's nascent because 442 is not enough. We need to do a lot more research in this field. But then they looked at particular what each study, what the quality is and what it reports, and they found about 61 were included in the review. So when I cite this paper by Ray, that's it's a synthesis of 61 prior studies on this non-motor symptoms. So to start out with first, that many of you may be familiar with is pain. And pain is really common in cervical dystonia. It's not seems to not be as common in the other forms of dystonia, but in cervical, there's been studies that report up to 3/4, so 75% experience pain. And this obviously can affect your ability to work, so it leads to disability, also has a significant reduction in quality of life due to pain, and maybe not surprising to this group here, but that it correlates with depression and anxiety. And so we did a study where I helped lead a study looking at what we call the Dystonia Coalition. So this was an international multi-center study that collected data from largely focal dystonia patients, so this and not related to any Parkinson's or other cause, so idiopathic dystonia. And part of the study, we looked at people who have been recently diagnosed. So they were diagnosed within the last 5 years. So this is recently diagnosed patients with isolated or idiopathic focal dystonia. And this is a depression scale called the HADS, or Hospital Anxiety Depression Scale. And what we found here, looking at pain, is that there was definitely a strong correlation between depression and pain. And we actually saw that across the different types of focal dystonia. And just to highlight anxiety as well, so this is a similar scale for anxiety, and then pain here is on this axis. And you can see that the cervical in red, those patients, and there was 255 patients included here, also had increased anxiety with pain. So then the question comes, well, is it a feature or response? So this is the chicken or egg phenomenon. So is it that dystonia comes and then that causes pain because of the muscle spasms? Excuse me. Or is it part of the disorder, a fundamental part of that disorder? Just a moment. Okay, apologies about that. All right, so just to take a little side step, and I will say, And thinking about whether this is a response or part of the disorder, I just want to go back and look at the brain for just a moment. So the brain is an amazing uh, organ. It is not this colorful, but it is just is amazing. And it is estimated that there are 86 billion neurons or brain cells in there. And that, for comparison, is about the same number of stars in the Milky Way, which is estimated to be about 100 billion. And if you think about all of these neurons, they all have connections to other neurons and multiple connections to multiple neurons. And so those are called synapses. And it's estimated that 1,000 trillion synapses are in our brain. So all these brain cells are connected to many, many other brain cells. And so that's a tremendous number. And it's far more even than the galaxies in the universe. So it's a huge number, not quite as big as the number of stars in the universe, in case you were curious. That's about 200 billion trillion stars in the universe. But the number of synapses and connections between these brain cells is just astronomical. And so, when you think about a question like, well, could pain be a feature of it? I think it goes back to chemistry a bit, right? So all these, so many things are connected in your brain, and they're all using various chemicals to communicate and send these signals back and forth. And if you look here, this just sort of highlights a lot of the structures that we think about in motor or movement disorders like dystonia. And in this network of brain structures, there's a whole list of brain chemicals that are involved in those communications. And particularly in dystonia, one of the ones that comes up quite a bit is a discussion about GABA. And GABA is the primary brain chemical or neurotransmitter, we call it, in the brain that inhibits. So it's inhibitory chemical. And so quiets the brain down. And you can imagine that if you have a loss of GABA, a reduction of it, that your brain's not staying quieted down, right? So that might cause, if it's in the motor regions or motor network, that might cause an increase in activity in the motor network if there's a loss of GABA. And so so we think about reduction in GABA being present in dystonia, while also in pain. It's well known that GABA plays a very important role. So there's two major brain chemicals that are involved in pain: glutamate, which is excitatory, and GABA, which is inhibitory. There's also lots of other brain chemicals, but these are two of the main ones. So just kind of sum up the pain and what we think might be causing it. I mean, there could be these muscle-based mechanisms where there's spasms and cramping from the contractions of the muscles that causes issues or causes problems with spine curvature and pinching of nerves and other problems like that. So it could be that. But there's also these non-muscle mechanisms that we've been talking about, which is perhaps it's GABA and related to the transmission and processing of the signals. So we call it ascending if you like step on a nail, and then that signal goes from your toe up to your brain. And then, but there's also pain pathways that go down from the brain. We call those descending. And so those often are inhibitory. And there also could be a problem with brain processing. So hopefully that's not too complicated, but I guess what I'm saying is that the pain stimuli occurs, and these are often glutamate, so the excitatory gets to the brain quickly to tell it that it's experienced some pain. Then it has to be processed in the brain. And if you look at these purple, this is processing that's involving GABA, which we think is maybe reduced in dystonia. And then you have descending, it goes back out to where you need to move your foot off the nail or do something to reduce the pain. And these mechanisms are inhibitory, GABAergic. So there's, so the loss of inhibition could lead to sort of chronic, more persistent pain. So that just makes me think that, my bias is that there could be just something about cervical dystonia that affects the pain pathways. And so it may be part of the disorder, not just secondary to the muscle spasms. So let's talk about treatment briefly. So because of the muscle contractions and spasms, being in one way or another contributing to pain. We often focus on trying to treat the dystonia symptoms themselves. We use botulinum toxin, that's the BONT, this is botulinum neurotoxin. We use analgesics, that's the ibuprofen, other kinds of pain relievers, and also muscle relaxers, which are very common. We have surgeries that we sometimes do. So we might selectively take out particular nerves to help limit the pain. That's an option. And then there's a large list of sort of non-pharmacologic options. So physiotherapy, biofeedback, electrotherapy, massage, dry needling, stretching. The evidence for these are not as good, but it is growing. There was just an article, I think, here in 2022 where this image comes from, where they were using kinesia taping as part of the therapy and treatment in cervical dystonia. And if you measure dystonia from an objective sense, that is from the doctor's perspective, the dystonia didn't get better in the study, so it didn't seem to help that. But the patients reported that they felt better, which is ultimately, what we're after anyway. So there may be some place for this in part of the therapy should you have pain. And then another thing we can talk about a little bit here is about improving sleep, and just the ability for your better sleep can help the neck muscles relax and help pain in the long term. So just to show some evidence, there was improvement in pain reported with both botulinum neurotoxin as well as DBS, deep brain stimulation, and improvement in quality of life with both of those as well. So there does seem to be a reduction in pain and improvement in quality of life as well with these motor sort of targeted treatments. So we do always consider those. So now to the next non-motor symptom, fatigue and excessive daytime sleepiness. They're not the same things, but I put them together here just because they're overlapping enough. And these are also very common. A variety of different studies show up to 45% of folks with cervical dystonia suffer from these symptoms. And one important thing to consider is that the medications that we use or prescribe to treat can play a role in this causing fatigue and sleepiness. And definitely these are rated the greatest among those taking anticholinergic medications. So this would be something like trihexyphenidyl or benztropine, Cogentin is the other name for that. And so, yeah, there's consideration of quality of life. You might have to look at what kind of medications you're taking. And I would say, interestingly, it turned out that when you looked at fatigue and daytime sleepiness, that there wasn't a difference from those taking benzodiazepines, which are commonly prescribed for folks to help them sleep, but also to help the dystonia and are generally considered to be sedatives. But there may be something different about dystonia, which that they don't get as sleepy when they're using them. And then as is the theme for today's talk, a lot of these are correlated with each other, and there's been studies showing that sleepiness correlates with depression. So it's often important if there is daytime sleepiness to think about other causes like mood. So then we'll step from sleepiness to sleep disturbances. So this is a bit different. This is looking at things that getting to bed, to staying asleep when you're in bed, and other aspects of sleep that don't have to do with tiredness, but the actual process of sleep. And sometimes those who have dystonia, cervical dystonia, don't know that they have bad sleep. So there's a difference often between what is reported versus some studies where they actually observed patients and brought them in sleep studies and then evaluated them compared to those controls who did not have cervical dystonia. So it's probably more common than you think. You might not be aware that some of your sleep is more disturbed than it is. But it looks like maybe up to 40 to 70% of folks with cervical dystonia have sleep disturbances. And this could be with difficulty getting to sleep, so initiating it, or staying asleep, which we call maintenance. And also the sleep efficiency, which is the amount of time that you are asleep when you're in your bed. So if you go into bed, but you have lots of restlessness and you're awake and having issues, your sleep efficiency would go down. And so there was reduced sleep efficiency found in 72% of patients with cervical dystonia. And lack of feeling refreshed was very common. I think this is common for many people, but it was more than controls in the cervical dystonia population. And again, sleep disturbances correlate with depression and anxiety. So how about the cause of these symptoms? So, there is a thought that is it part of the muscle movements and contractions that is relating to it? Is that why you're feeling fatigued, or is your sleep disturbed? So arguing against this idea is that there's many people without pain who have dystonia. So maybe a quarter to half of cervical dystonia may not have pain, and other forms of dystonia don't have pain. And they similarly have these sleep disturbances. So sort of arguing against that it's just the muscle contraction. The other thing is that the frequency and the duration of the sonic movements is reduced during sleep. So some people may feel like they don't feel rested in the morning, or that their neck feels just as bad in the morning as some people. But it does look that if you're getting into deeper stages of sleep or REM sleep, that the dystonia and the sonic movements are markedly reduced. So there may be light sleep though, where you wake up or you're in a light stage of sleep that you do experience some. The other thing arguing against this being just a response to the dystonia, the movement symptoms, is that it's been shown in a handful of studies to not correlate with the severity of the dystonia. So to say there's not a connection there. And just similarly, when botulinum neurotoxin was used to treat the dystonia, it didn't appear to improve the sleepiness and or help the sleep disturbances. And there's a number of studies showing that. And then coming back down to the correlations we've been talking about, that these symptoms correlate more with depression and anxiety levels than they do with motor severity. So it's kind of linking the non-motor symptoms as being more key. So what can we do in terms of treatment for these non-motor symptoms? Well, again, let me talk about anticholinergic medications can make you quite sleepy or have issues. We have to review the medication list, think about how much of a component we're playing as providers and giving you particular medications, and try to make benefit to risk sort of assessments. And then also, as I mentioned, all the way these are correlated with depression, anxiety, but also with pain, is really to make sure we're considering the whole patient and thinking about these disorders when we're trying to treat something like fatigue and sleepiness, sleep disturbances. It's important to think about what else might be going on. Exercise seems to be important for all of our neurologic disorders, but in dystonia as well. And it seems that if there's more exercise during the day, you actually sleep better at night. And if you sleep better, that should help reduce some of the fatigue and sleepiness. And then if none of those work, we try things like hypnotics. So this is sleep aids. There's a whole variety of them, often overlapping with muscle relaxer categories of medications. Sometimes we use stimulants during the day to help keep people who have excessive sleepiness. And then, of course, you can consider alternative and complementary therapies as well. So people are looking into CBD to help their sleep and pain. And so these are viable options. All right, so the next thing we'll talk about is moving on to the next non-motor symptom to discuss today, which is anxiety. And so just to define it here, so we're all on the same page. So anxiety is a feeling of worry or nervousness or unease. It's typically about some imminent event or something with an uncertain outcome, but it can also just be a feeling. And it's common, and we all have anxiety. Everyone does, and some argue it might even be like another vital sign, right? You have your height, your weight, and your level of anxiety. And we know this fluctuates day to day, month to month, pandemic to pandemic type thing. But when it becomes a disorder or a problem, then it needs to be addressed. And so this is the definition of a general anxiety disorder, generalized anxiety disorder. This is when there's excessive worry that's difficult to control, and it occurs for at least 6 months. This is a psychiatric definition of it. So in other words, it's enduring. It's not going away. The other thing I would put into the diagnosis definition is that it's impairing, it's disabling. If it starts to affect your day-to-day functioning or life, then it's a problem. It needs to be addressed. Another type of anxiety is called social anxiety disorder. So this is similar, but it's often this intense fear or anxiety in certain social situations. And it can be because you feel like you may be judged, embarrassed, or humiliated, but it generally leads to the same thing of avoidance of being in public or around people. And so, referring back to this study by Ray, and this is the literature reviews, there was anxiety was present in up to 70% of patients with cervical dystonia. And I'd say it's pretty close to what I see in my clinics as well. It is a very common symptom. Lifetime prevalence, which means like what's the chance that you're going to have it at some point over your life, that it's a disturbance or bothersome. That's up to 86%. And this social phobia, this fear of being in crowds or around people, can affect up to about 55%. And as no surprise, this can contribute to disability as well as diminish quality of life. So important things that we want to address. This is from the study that I mentioned before with the Dystonia Coalition. Again, we had 255 recently diagnosed cervical dystonia patients, but we also had other focal dystonia types. This is SD spasmodic dysphonia, the hand dystonia, or mandibular dystonia, blepharospasm. And this is looking at anxiety. And what we thought too is in the study was to look at, are there differences between those with cervical dystonia and other forms of dystonia. So this is a scale of anxiety on this side, and this is cervical. So you can see our rating was roughly that a little slightly over 40% had what was thought to be clinically significant anxiety. And this was about the same as those with cervical dystonia, but quite a bit higher than those with blepharospasm, showing that there may be some differences between the different types of dystonia and levels of anxiety that are experienced. When we looked at social anxiety, this is with a different scale, but it's a scale that measures how much social anxiety one has. And the numbers, again, in the cervical group were very similar, a little bit over 40% having social anxiety. And but in this case, the spasmodic dysphonia had much greater social anxiety than the cervicals, but this is still high level of social anxiety amongst all of the groups. So let's talk about something similar, which is depression. So depression is a mood disorder. This is a bit different than anxiety, but it's where one experiences a persistent, depressed, sad mood, and loses interest in doing things or being with people. And it's a disorder, actually only takes a couple of weeks of not, of this kind of state to be called depression. And depression is also important to know about because it's not always presented in the same way as someone being sad or tearful. There's often just lots of changes, and maybe just their sleep is really noted, or maybe they become more irritable and have more anger or outbursts. So it's not always just sadness, but it's often associated with this fatigue and lack of energy and sleepiness and trouble focusing and concentrating. So it's important to know that it doesn't always present just as sad or despair. So in cervical dystonia, there's a variety of studies that support that it's maybe as common as up to 50% experience depression. And if you look at lifetime prevalence, these are different studies, so it goes up from there. But this might be, if you have depression, that it's sort of there for the long haul. It's also something that contributes to disability, no surprise, and correlates with quality of life, as we mentioned. And then go back to the study with the Dystonia Coalition and these recently diagnosed patients with depression. That's on this side. We have a different scale here. And we found this is, with recently diagnosed patients that there was about 30% even at that time. So, the time that they presented. And there's no arrow, there's no asterisk here to show that there was any differences amongst the groups. So even though they look like they're bouncing around, there was no difference across the different types of dystonia types. So that suggests that, if we're trying to say, is this something that's just part of dystonia disorder, or is it the neck spasms themselves that cause it? This would suggest that depression might be part of the disorder, because it doesn't matter where the dystonia is affecting. We often lump these two things together, depression and anxiety, but they are separate, they're different, they have different sets of symptoms, but